Hello students, welcome to the discussion of the MCQs and the topic is the cardiovascular system, right? So we consider here the first question. A 3-month child has been brought with history of irritable cry, tachypnea and bluish discoloration of lips, fingers and toes. Oxygen saturation 75%. All of them basically are the findings of so-called hypoxic spell or the cyanotic spell. There is single S2 and presence of ejection systolic murmur at mid-left sternal border. So single S2 along with cyanotic spell is seen in TOF because in the TOF P2 is soft and delayed. So that is not audible. Only A2 is audible. Then there is ejection systolic murmur at the mid-left sternal border, which signifies there is pulmonary stenosis. There is pulmonary stenosis. So this is a diagnosis of tetralogy of Fallot. And in tetralogy of Fallot, there is no murmur of VSD. Why? The pressure in right ventricle, left ventricle and aorta is equal. So there is no pressure, no murmur of VSD. Yes, there is right ventricular hypertrophy. There is oligamic lung fields because there is decreased pulmonary blood flow. Because the pulmonary blood flow is decreased, you get is the oligamic lung fields. Now, polycythemia is something which can be seen in any cyanotic congenital heart disease because due to hypoxia, there is increased level of erythropoietin. There is increased level of erythropoietin. So the right answer here is the presence of pansystolic murmur is not a feature of TOF. On chest X-ray, an oval-shaped heart due to enlarged right atria along with a narrow mediastinum. Now you basically see they are saying is a oval-shaped heart like this, right? And there is this narrow mediastinum. So this is so-called the string, and this is the egg. There is another way of framing the question of the egg on a string appearance, which is a feature of the transposition of great arteries. This string is because of the narrow mediastinum. And why the mediastinum is narrow particularly, both arteries oppose each other. And they are like this. If they are opposing each other, even the thymic shadow is not visible. So you get a narrow mediastinum. Along with this, there is enlargement of the right atria. So this portion enlarges. So this gives a oval shaped heart so-called with a narrow mediastinum. That is something you say is the egg on a string appearance, a feature of transposition of great arteries. Which of the following is not true regarding fetal circulation? Highest oxygen saturation is in umbilical vein. Yes, because umbilical veins carries the oxygenated blood from the placenta. SpO2 is more in inferior vena cava. Yes, because this umbilical veins, this particularly umbilical vein, they join the ductus venosus, which join the inferior vena cava. So the oxygen saturation in inferior vena cava is more than SVC because IVC is having both oxygenated and deoxygenated blood. Blood from superior vena cava flows across foramen ovale from right atria. No, it is the blood of inferior vena cava which basically flows from the right atria to the left atria through foramen ovale. Pulmonary vascular resistance is more. Yes, PVR is more than SVR. That's why in the fetal circulation, if you see, the blood flows from pulmonary artery to aorta. So which is the not true one? The C point is not true here. A 15-year-old girl has history of loss of appetite and fever for the last 1 month. There is low platelet count which is there and muffled heart sounds. Mother says she has rash on the face when she comes to the school in the afternoon. She comes from school actually. She comes from school in the afternoon, most likely diagnosis. Now you see a fever for the past 1 month. There is thrombocytopenia. All of them in a 15-year-old girl can be explained by SLE, and the muffled heart sounds can be due to the pericardial effusion. Pericardial effusion. There is a rash on the face which is there in the afternoon, malar rash. Basically, the child is coming back in the afternoon, the redness can particularly increase. So, this is SLE. A 6-year-old girl presented with swollen right knee after recovery from swollen ankle last week. She had rash over her extremities. There is also history of sore throat last week. Essential criteria. Now, if you see in rheumatic fever, there is migratory arthritis. So first it was swollen ankle. Now it is swollen right knee. Rash over the extremities. This can be particularly what we say here. This is erythema marginatum. This is what we say here is particularly erythema marginatum, right? Then there is a history of sore throat because rheumatic fever follows the pharyngitis. So how do we confirm? What is the essential criteria? That is evidence of streptococcal infection. So how is the evidence of streptococcal infection? That in this scenario can be by the rising ASO titer, or it can be positive throat culture, or it can be positive throat culture, right? ESR, CRP, first degree heart block on ECG is suggesting the prolonged PR interval. This or are included in the minor criteria, not in the essential criteria, not in particularly the essential criteria. A 6 weeks old child has history of breathlessness for the last 3 days, difficulty in feeding for 2 days, failure to gain weight. On examination, heart rate is 160, respiratory rate 65, there is tachypnea which is being present, SpO2 is normal, normal perfusion, there is a audible systolic murmur at the left lower sternal border. So systolic murmur at the left lower sternal border, all this can be particularly seen in the VSD. That is the VSD. If you particularly see the saturation is 98, which cannot be seen in TOF, cannot be seen in tricuspid atresia. And in the pulmonary atresia, there is the ejection systolic murmur. There is basically the ejection systolic murmur. So this is basically what we say is the VSD answer. A 15-year-old girl presented with exertional dyspnea. It is a 15-year-old. She was diagnosed as CHD in infancy, but no treatment was taken. On auscultation, there is loud P2, early diastolic murmur at the left upper sternal border. Oxygen saturation in right upper limb and lower limb is 98 and 76, most likely. So now if you see one by one point here, the saturation in the upper limb is normal, lower limb is saturation less. So this becomes the differential cyanosis. Differential cyanosis, and this can be seen if there was PDA with pulmonary hypertension, right? And if there was particularly pulmonary hypertension, there is loud P2. That also suggests early diastolic murmur can be because of tricuspid regurgitation, which can be seen in this condition. So this basically is a child of patent ductus arteriosus who did not went for surgery. This resulted in the differential cyanosis. Drug dependent flow is required in all of the congenital heart defect except coarctation. Yes, in the particularly infancy, the lower portion requires the blood through this. HLHS also we say the systemic circulation is ductal dependent. Systemic circulation is ductal dependent. In TGA, if the ventricular septum is intact, the only thing which can cause particularly the blood is in this scenario, right? So out of these four, the pulmonic stenosis is the right answer. But remember, if it is a severe pulmonic stenosis, in that condition also, if it is a severe pulmonic stenosis, in that condition also, what can be particularly seen in that situation, pulmonary circulation is ductal dependent. Pulmonary circulation is ductal dependent, right? So we add here systemic dependent blood flow is required in all of the condition except is the pulmonic stenosis. Pleothoric lung fields are seen. Pleothoria means the pulmonary blood vessel markings are prominent. So what we say, this will be seen if there is increased pulmonary blood flow. Now this increased pulmonary blood flow can be seen in ASD, supracardiac type of TAPVC, in VSD, but in Epstein's anomaly, there is decreased pulmonary blood flow. And because there is decreased pulmonary blood flow, what we get is basically oligamic lung phase. What we get is the oligamic lung phase. Features which can be seen in coarctation of aorta in an 8-year-old child. Now, if you particularly see in the coarctation 8-year, that means it is mild to moderate. So, if I just say here, let us suppose this is the coarctation which is here. So, what is happening in this condition? The lower limbs are getting the less blood. Upper limbs are getting the more blood. So, there is bounding pulses in upper limb. BP is more in upper limb as compared to lower limb. Now, because of this coarctation, left ventricle needs to apply the force, left ventricular hypertrophy. But in this case, there is radiofemoral delay. The meaning of radiofemoral delay is radial pulse is palpable earlier than the femoral pulse. Radial pulse is palpable than the femoral pulse. So, this is not correct here, right? So these were some of the questions related to the CVS in the pediatrics parts. Thanks for watching, right? And you can follow me all over here. Thanks.